Hey everyone, my name is Brandon Bush. I'm an internal medicine resident at University of Louisville. I'm presenting a clinical vignette titled Don't Rely on the Read, Have Confidence in the Context. There are a lot of learning points in this case, but there are two I specifically want to focus on. The first is to discuss the importance of clinical presentation as the driving force behind clinical decision making, and the second is to review a case that highlights our potential overdependence on imaging studies and how clinical reasoning helped prevent a near miss from becoming an adverse event. Starting with the admission of this patient, is a 33-year-old female who presented with nausea, vomiting, right upper quadrant abdominal pain for 3 days and radiating to her right shoulder. She was AV febrile with her vitals within normal limits. She had normal CBC, lipase, as well as liver enzymes. A CT abdomen was obtained in the ED, which showed slight gallbladder wall thickening without evidence of cholelithiasis, common bile duct measuring approximately 8 millimeters in the porta hepatis without visible obstructing lesion, as well as a possible enhancing mass in the right inferior hepatic lobe. You can see in the CT here with the bile duct outline in red. On day 2 of admission, MRI abdomen with liver protocol was obtained, with the read indicating no evidence of cholelithiasis and a 1.6 centimeter arterial phase enhancing lesion in the right hepatic lobe, most likely focal nodule hyperplasia or adenoma. On day 3 of admission, her pain continued and her liver enzymes began to rise. She then had an AST of 97, ALT of 96, a T-billy of 2, and ALK Phos of 120. HIDA scan was obtained given the clinical suspicion of cholecystitis, even though there were no stones mentioned on the MRI from the prior day. It showed homogeneous activity in the liver with no excretion of radiotracer into the biliary tree or gallbladder after 90 minutes, consistent with high-grade obstruction of the common bile duct. This was concerning as there was no mention of stones obstructing the common bile duct on the MRI from the day before. The previous MRI abdomen was reviewed a second time by the radiologist, who then noted the presence of 2 distal common bile duct stones measuring 4 to 5 millimeters without upstream biliary dilation. This was missed on the initial read. ERCP was performed and showed bile duct dilation with the presence of 2 5 millimeter stones, both of which were successfully removed by sphincterotomy. You can see in the cholangiogram in the top right images. Liver enzymes were improved the next day, and the patient was discharged home with a plan for elective cholecystectomy. This case illustrates how overdependence on imaging studies has the potential to mislead clinical decision making. Radiology reads are often considered the end-all be-all as if they were as diagnostic as a biopsy, when in reality they are a static picture of a dynamic process and prone to reading error. This case would have been straightforward if this first CT or MRI read indicated the presence of gallstones. This radiology read error is classified as a satisfaction of search error, where the radiologist was focused on the apparent benign liver lesion rather than other potential pathology. Fortunately, in this case, HIDA scan was pursued given the high clinical suspicion for gallstones. If the diagnosis of choledocholithiasis was missed, this patient would have been at risk for acute cholangitis with its associated high mortality. In conclusion, the patient's clinical presentation should be the primary driving force behind our clinical decision making, with imaging studies being utilized in an adjunctive manner. Thank you for listening. I hope others can gain as much from this case as I have.